So we're going to continue on with neoplasms, our discussion of neoplasms. So there's all kinds of tests that are done. Some of them are routine in trying to pick up, and screen for these things. Some of them are to monitor the effectiveness of treatment. Some of them are original diagnostic to explain the symptoms that people present with. So, of course, blood tests look at thrombocytopenia and erythrocytopenia and leukemia, etc. We can also do blood tests as screening tests for like PSA, the different antigens, that kind of thing, looking for enzymatic markers of tumors. We do scans, CT scans, MRIs, and just plain film X-ray. So like a mammogram is a plain film X-ray. We see something, it probably requires a CT scan to follow up. This is a picture of a CT scan of a skull. There's the brain and there's a tumor and a cyst next to it, so a big hollow spot. These things are useful tools, not only for diagnosis, but for monitoring. So we look at the different enzymes and antigens, hormones. If we suspect a paraneoplastic syndrome, they start looking at the hormones very closely. So PSA, for instance, are some antigens. So here's a kind of a list of things that are indicative of things. So we wouldn't do a CEA unless we suspected that there was a colon cancer. Biopsies, pap smear, colonoscopies, those sorts of things. I myself have got a family history of colon cancer. My dad had colon cancer. My grandmother, his mother, died of colon cancer. On my mother's side, my uncle had colon cancer and my aunt had colon cancer. So I started getting colonoscopies when I was 40, and I've been getting them every 3 to 5 years since, screening. And every time that I've had one, there's been a polyp, and like my surgeon says, not every polyp turns into cancer, but every cancer starts as a polyp. So they've always been biopsied. They've been taken and evaluated. And it turns out none of them were anything more than just plain mucosal polyp. But nevertheless, it's better to be safe than sorry. Catch these things early. Breast self-exam, testicular self-exam. These things are all important kind of screening tools. You want to detect, catch things early. Okay, so back again to metastasis. Spreading. So when the hallmark of a malignant tumor is that it spreads, that it can affect other tissues other than the tissue of origin. There's 3 basic mechanisms. Malignant tumors can spread by 1, 2, or 3 of these mechanisms. Early on, the spreading is by local spread. It's by invasion. So the tumor grows and it outgrows the tissue that it's in and starts to invade the tissues next door. And we'll start to take over that. And so that's a local spread. That's invasion. Metastasis is when the cancer and the cancerous cells spread through distant sites by either blood or lymphatic. So with angiogenesis, there are blood vessels enter the tumor. Cancerous cells can enter the bloodstream, and then deposit someplace else. Now, there's this idea that different types of tumors have preferred locations to settle down and start a new colony of tumor, of cancerous cells. And so, like, for instance, prostate will metastasize most often to bone, as will lung cancer, where, different cancers metastasize to different things. Liver cancer seems to somehow end up going to the brain a lot, things like that. Seeding is when the tumor is in an organ, in one of the cavities. So say it's a tumor of the kidney, and the tumor spreads into the peritoneum of the abdominal cavity, and then will seed through that and end up like on the outside of the large intestine or something like that. So it's kind of halfway between this local spread invasion and this spread by fluids. Seeding is kind of spread in the membranes or the body cavities in the fluids there, rather than the fluids that are flowing. So here's kind of a picture. So the primary tumor cells end up in the lymphatic or in the veins. If it's in the lymphatic, it ends up in the lymph node. Maybe will grow there and then start shedding, and that eventually enters the veins. It lodges in a capillary bed in a hospitable tissue, and then you get another tumor starts to grow there, and you end up with multiple tumors. So here's an example of that. So the primary cancer is a tumor in the breast. It spreads to the lymph nodes in the armpit. Then that follows the lymphatic vessels, ends up in the vena cava and in the heart, spreads, so if it ends up on, because the vena cava ends up on the, going into the right atrium, it will then, the next place it goes is to the lungs, because it goes via the pulmonary arteries, and so you can get a metastasis to lung from breast. Then from lungs, it can end up going from there through the left atrium, left ventricle, and out the aorta, where it can get to any organ in the body. So it can go to the ovaries or the liver or any other place where the blood supply goes. So it tends to follow this pattern. So if they are looking at a breast tumor, the first thing they're going to investigate is it got to the lymph nodes. If it's got to the lymph nodes, it's okay, now we're going to start looking at lungs. If it's gotten to the lungs and we're seeing mets to the lungs, then as it's going to spread via the arterial blood supply to any organ. So that's when you start looking all over. So it could be in the brain, liver, ovaries, just about anywhere could be the mets from that. So this is a chart, and I don't know why the title is removed, but this is comparing benign tumors to malignant tumors. So the cell characteristics in benign are similar to normal, they're differentiated, they have a higher mitotic rate, but still controllable. Slow-growing ones are almost normal. They grow slowly, it's an expanding mass, usually encapsulated. They don't spread by metastasis especially. It stays a local, They don't usually have systemic effects. It's usually local effects, and unless it's going to interfere with vital function. So like if it's a benign tumor that is compressing on the aorta, for instance, you're going to have circulatory problems. It usually doesn't destroy tissue. It can get local necrosis and cause infection and have secondary damage. Interfering with blood flow is the biggest thing. And will only kill you if it starts to really impact vital organs. So benign brain tumors are really like filled in that category. Also maybe pericardial, those sorts of things. A malignant tumor the cells will become undifferentiated, huge rapid mitosis. The nuclei tend to be large, but the cells are dividing before they've even made enough cytoplasm, so they're really varied in sizes. You get this rapid growth, and you get more anaplastic cells, which then leads to more rapid growth. Cells don't stick to each other. The surface membranes and the proteins that are made that hold cells together are not in fact made. There's no time for it, and so the cells come apart, which then leads to this idea that they can seed or they can metastasize. There's no capsule, so they invade nearby tissues or they metastasize distally. So they usually have systemic effects, because especially after metastasis, because multiple things are happening at once. Usually anemia and weakness and weight loss are the first presenting things, but those are systemic effects. They are destructive. They will rob other areas of blood if there's angiogenesis, and they produce substances that are toxic to cells around. They usually lead to death unless it's controlled. That's why they're malignant. So we're back to this whole staging idea. So we look at this usually at the time of diagnosis and then repeat it through to kind of judge the effectiveness and the efficacy of treatment. It describes the basis of treatment, and this is where prognosis comes in. And those are all statistical probabilities. So T and M. T is the tissue, and it's really the size of the primary tumor and where it's located. N is if it spreads into the lymph nodes. M is if it's metastasized distally. So here's a couple of different ones, how they stage. So for instance, they look at, so occult means hidden. So if we're looking at non-small cell lung cancers, so they find cancerous cells in the mucus that's coughed up, but they can't find the tumor. Stage 0 is the lung cancer is found only in the cells lining the air passages. So this is in situ, it's called. So there's a tumor, it's detected, but it's limited just to that mucosa. Stage 1 is the tumor is smaller than 3 centimeters and hasn't spread, 1A. 1B is the tumor is larger than 3 and hasn't spread. But both of them, you'll notice the tumor hasn't spread. Stage 2 has spread to the nearby lymph nodes. And 2B is spread to the lymph nodes within the same lung and membranes that surround the lung, so the pleura. Stage 3, the cancer is confined to the lung itself and the lymph nodes within the chest. If it's 3B, it's probably lymph nodes outside the chest. Stage 4 is when it is spread to other organs, liver, bone, things like that. And you'll see that the staging of ovarian cancer down here is basically the same. Stage 1 is the cancer is in situ, it's within the ovary. Stage 2, the cancer is in one or both ovaries and is spread to other organs in the pelvis, so the bladder, the colon, whatever, the uterus. Stage 3, the cancer has spread beyond the pelvis into the lymph nodes. Stage 4 is metastasis to distant organs. And so there will be a chart like this virtually for every type of cancer. This is one for renal cancer. So no evidence of a tumor is T0. So T1 is a small tumor, T2 is a little bit bigger, T3 extends into the major veins and peripheral tissues, but not beyond the fascia. The adrenal gland, perinephric tissues, etc. I'm not going to have to read that. T4 is beyond the fascia. Is it in the lymph nodes? No. Is N0, N1, N2, N3, and then distal metastasis? None. Or there is. So M0 or M1. So we say stage 1 is if we're at T1, N0, M0. Right? So small. But stage 2 is a T2, N0, M2. Stage 3 is all of this. Stage 4 is T4 or any T's, any N's, or M to distal. So if we see an M1, which is metastasis to distant mets, it's stage 4 automatically because it doesn't matter what the T at the end is. So again, we can break this out. I'm not asking you to memorize this. It's for demonstration purposes to see how these things work. So all that money to cancer research, all the Princess Margaret Hospital lotteries and things are doing all kinds of research to see if we can figure out what triggers cancer, right? A lot of it is genetic. There are genes that repair DNA. If that DNA is not properly repaired, then there's going to be problems. So what causes the gene that repairs the DNA to malfunction? Programmed cell death, so apoptosis. If that doesn't happen, then these undifferentiated cells, so these bad cells, don't die. There are things called oncogenes, which are genes that would cause cancer if they're activated. There are tumor suppressing genes, and we really feel that these oncogenes are probably got more to do with trying to create stem cells to repair tissue damage. It's probably a protective mechanism, and then the tumor suppressing genes are supposed to prevent them from getting becoming cancerous, to becoming tumors. But really, it's changes in the DNA that is the root causes of these transformations. So what can cause this to happen? It can be all kinds of risk factors. It can be anything that's going to screw up the DNA, and then you get that being repeated, that being spread, that screw up being spread through mitosis. So this could be a combination of factors. It could be the same factor repeated over and over again, like smoking or sunlight on the skin, things like that cause the genes to be damaged and not repaired. And you get this transformation of normal cells into these cancer cells that hopefully will be detected by your immune system and removed. But if they're not, then they can start to reproduce. So we look at the initiating factors that cause this irreversible DNA change. So the procarcingens that are going to cause DNA change that can't be repaired. So these genetic changes cause this mutation, or there could be some environmental thing that causes, but you don't get an active neoplasm from there. You need a promoter that pushes that, the growth of that, and you'll get some dysplasia, maybe even get to anaplasia. You get this increased rate of mitosis. That's what the promoters do. So this could be hormones or different chemicals. And then you get the third stage is this malignant tumor idea. So if you look at this, we have this kind of initiation. So we get some irreversible mutation of the DNA. Something is screwed up ever so slightly. That could be either a transcription error in DNA replication as a cell is undergoing S in the interphase. That kind of stuff happens, and it can just be random. It could be caused by some sort of radiation. It could be sunlight. It could be viruses that get into the cell. But something is causing this change of the DNA. Right. Then we get this repeated exposure to carcinogens, or you get these risk factors. So again, it could be viruses, could be repeated sun exposure, repeated damage, could be smoking, that kind of thing. And then that's going to further this damage. Then we get the promoters, could be hormones, kind of industrial things, food additives, any of that kind of thing. And then it becomes cancer. So we start out with normal cells, and then something mutates in it, and this mutated cell will start to reproduce, and then due to repeated exposures, we get membrane changes, and then somehow slips under the immune surveillance and then starts to reproduce and becomes malignant. So what's the best way to deal with cancer? Well, detect it early and you get the best prognosis. So interestingly enough, the cancers that make you the most sick with the highest levels of symptoms are the ones that are detected the earliest and actually have the best prognosis. Ones that are detected later have the worst prognosis. So there's hardly any symptoms to pancreatic cancer. So most pancreatic cancers are already at stage 3 or 4 when they're detected. Lung cancer, the symptoms are so ubiquitous, cough and sputum and stuff. People think, well, it's my COPD acting up or whatever. So they're usually far along before they're detected. Things like prostate cancer, because of widespread screening for PSA, are often detected early, and they tend to be very slow-growing cancers. So, and the symptoms, the symptom is it becomes very difficult to pee. And so there's a lot of public education in that, and so it gets looked at and caught early. So the best thing to do is detect it early, which is why screening tests, colonoscopy, mammograms, things like that are effective. Once it's diagnosed and caught early, then what do we do? Well, if it's in situ, we cut it out. Surgery is a big deal. Remove the tumor. If it's caught early enough, that might be quite effective. Radiation works as well. So cut out the tumor, radiate the area, and kill any cells that are in mitosis in that area, and catch any of the cancer cells that may be locally invasive. Radiation only works for that in that local area. You can't do full body radiation. Chemotherapy is if you suspect metastasis. If you think that it's spread, well, then you need a more systemic approach. And chemo and immunotherapies are more systemic, and it tracks down these different sites of tumor metastasis. Chemotherapy is becoming more and more targeted and is less harsh on people than it used to be. It used to be that people would say, I'd rather die from the cancer than undergo chemotherapy one more time. The main thing for chemotherapy is that it's any metabolically active, any cells that are undergoing mitosis. So stomach lining, the entire mucosa from your entire digestive system, from your mouth right to your anus, gets targeted. And so anorexia and bleeding and discomfort are a problem. Hair falling out, skin lesions, things like that can be really difficult side effects to the chemo. Immunotherapy is more targeted. It goes after the specific markers, and that's a good thing. These targeted molecular therapies are really even better because you're going after specific markers that are on the tumors. Stem cell transplantation is often something that people are looking at, and it's like, okay, well, let's replace these damaged tissues. Let's compete with the tumor, and those sorts of things. So the problem sometimes with the surgeries is like, okay, so can you remove a big chunk of the liver? Can you remove a kidney? Yes, but what if it's a tumor in the heart or something? Like, you can't cut out a chunk of that without causing severe damage. So those are the sorts of things that come into consideration. So you catch it early, right? So the tumor starts to grow, the signs appear, you get the diagnosis along the timeline, right? And then you do surgery, right? Maybe chemo or radiation, and you get cured. If it resists the treatment, chemo and radiation might cure it. You may get reoccurrences, or it might just accelerate to death, and that's when you would really start dealing with palliative treatment. So if the tumor is continuing to grow, then you make the decision, let's make this person as comfortable as possible until they pass. So they used to do radiation by beaming radiation on the tumor. Now and cobalt and radium with the big things, you want to target it very closely and make sure that it doesn't affect the healthy tissue that surrounds. But it can cause all kinds of damage to the epithelial cells overlying it. It's very hard on people. Now, and unfortunately, they use the term seeding for it. They seed tumors. With some tumors, they actually use a needle and they inject little seeds of radioactive material into the tumor itself, and so there's this ongoing low radiation that shrinks the tumor. That's happening a lot with prostate cancer. And as a matter of fact, my father was the first person in Canada to get that treatment. It was made available in the States about a year before my dad was diagnosed, and he was the perfect candidate, so he had it done at McMaster University as part of a demonstration of the efficacy of it. And he died 25 years later of lung disease, not of prostate cancer. It worked great for him. Chemotherapies, most of them are antimitotics. Some of them are antimetabolics, so this slows down the growth. Usually there's antibiotics involved because for secondary infections. The biggest problem of these is that it's going to target any cell that's in mitosis because it's antimitotic. And so you can end up with problems of like the mucosa, problems of hair follicles. You can end up with scarring and tissue damage, bone marrow, because hematopoiesis is a lot of mitosis. You can get some pretty severe side effects from that. There are other things. There are hormone therapies. A lot of times, guys with prostate cancer get estrogen. And like a lot of tumors depend on their growth on sexual hormones, and so if you testosterone can be counteracted with the estrogen. Interferon, angiogenesis inhibitors are important to disrupt blood vessel formation if it's caught early enough before there's vascularization. We use analgesics for pain control, glucocorticoids, so these are the steroids, like things like prednisone and things like that. They help with inflammation. Nutritional counseling, marijuana so that it increases appetite, things like that. Here's some picture of skin cancers. There's 3 different ones here. This one is a basal cell carcinoma. You'll notice it's got this ring around it, and it's raised and it's kind of pearly. That's typical of basal cell carcinoma. It grows slowly, and is very easily treated. A squamous cell carcinoma happens in the more superficial layers and often gets in the necrotic center, so it ulcers like this. This is a melanoma, and there's it's raised. There's color differentiation. The borders are indistinct. So when you compare it to an ordinary mole, it has this characteristic loss of shape, loss of borders, various colors. This can be quite a dangerous cancer right there. And so there's all kinds of risk factors. It seems every time we turn around, there are risk factors for cancer. Carcinogens are everywhere, but there's genetic basis. So things like colon cancer runs in families. That's why I get tested as often. Viruses can do it. Exposure to radiation, that's why when you get x-rays, you often are covered with, dental x-rays, you wear the apron and stuff like that. Different chemicals, so especially solvents can be bad for that. Chronic inflammation, irritations, so that's things like breathing asbestos, it becomes chronic irritation. Bad diet, hormonal imbalances. Nothing much you can do about age. Increasing age as a risk factor is like the alternative of not aging is not really a viable alternative. So cancer rates go up as we get older.